Okay, now labor. So we are having a scenario that there is a fetal and maternal anatomy related by labor and the important definition in it and mechanism of the labor. So we will discuss the fetal and maternal anatomy and the important definition in it and the mechanism of labor. Labor, fetal and maternal anatomy relevant to the labor. So we are having the pelvis. In pelvis we have the pelvis inlet, then the mid cavity, and then the outlet, and then the pelvic floor. In the pelvic inlet, on posterior side, the promontory of sacrum is present. The transverse diameter is 13.5 centimeter and anterior-posterior diameter is 11 centimeter. The bounded anterior by symphysis pubis and on each side by upper margin of the pubic bone, iliopectineal line and ella of the sacrum is present. Now the pelvic mid cavity, we are having the posterior, which is second and third section of the sacrum. It is round and anterior by middle of symphysis pubis, each side by pubic bone, obturator fascia, inner aspect of the ischial bone is present. The pelvic outlet, the posterior side sacrum is present, 13.5 centimeter its diameter, and anterior it is covered by lowest part of the symphysis pubis and each side by descending ramus, ischial tuberosity and sacrotuberosity and ligament. So you should remember this one. The diameter is the important, that is the inlet is 13.5 centimeter. Then it is okay, and the pelvic outlet is also 13.5 centimeter. Okay, now the types of pelvis we are having. Types of pelvis, we are having four types of pelvis, that is gynecoid pelvis and android pelvis, arthropoid pelvis and platyploid pelvis. So the gynecoid pelvis is more favorable one for the delivery of the fetus, and android pelvis is deep transverse arrest, and anthropoid pelvis occipito post position, and in the platyploid pelvis increased risk of the obstructed labor is there. Okay, so the gynecoid pelvis is the favorable for the delivery. In android pelvis, the deep transverse arrest during the delivery occur. In anthropoid pelvis, occipito post position occur, and in platyploid position pelvis, the increased risk of obstructed labor is there. The pelvic floor is made up of levator and eye muscles, and the perineum is final obstacle. It is found between the vagina and the anus. So this is the fetal anatomy. This is the fetal and maternal anatomy relevant to the labor. Now the fetal presentation. Sub-occipito-pragmatic position, which is 9.5 centimeter, and it is well flexed. Then the occipitofrontal position, and it occurs in the 11.5 centimeter, and it is partially extended state. Then occipitomental position, and it is 13.5 centimeter and extended drop presentation. Then submental pragmatic, which is 9.5 centimeter, and face presentation hyperextended. What is presentation? It is the position of the fetus in relationship to the maternal pelvis. Presentation is the position of the fetus in relation to the maternal pelvis. These are cephalic position, breech position, and compound position. Then we are having the lie. It is a relationship of the longitudinal axis of the mother to the longitudinal axis of the fetus. These are very important definitions. The lie are longitudinal, transverse, and oblique. Okay, so what is presentation? It is the position of the fetus in relation to the maternal pelvis. And what is the lie? It is the relationship of the longitudinal axis of the mother to the longitudinal axis of the fetus, which are transverse, oblique, and longitudinal lie. Now we are having attitude. It is a relationship of the fetal head and limbs to its trunk. Engagement, when the largest diameter, that is biparietal diameter of the presentation part, pass through pelvic inlet, it is called engagement. Position, it is a relationship of the different fetal part to the maternal pelvis. Station, it refers to the degree of the descent of the fetal presenting part through birth canal, and it is expressed in centimeter above or below ischial spine. Then what is deep transverse arrest? It is a delay in second stage of labor, and it can occur due to android pelvis. This results in the arrest of the descent of fetal head at level of ischial spine at transverse position due to android pelvis. Then what is augmentation of the labor? The process of accelerating the process by labor by the use of oxytocin and amniotomy in a uterus that has started the process of labor is augmentation of labor. Okay, augmentation of labor is the process of accelerating the labor by using oxytocin and amniotomy in a uterus that has started the process of labor. Okay, these are also the we have discussed the anatomy of the maternal and fetal anatomy relevant to the labor. Then we have discussed the different fetal presentations. And then we have discussed important definitions in the field of obstetrics, which are presentation, the lie, the attitude, the engagement, the position, the stages, and then we have discussed the deep transverse arrest and the augmentation of labor. Now we have a scenario which is of labor, that there is a G2P1 presents at term to labor room. On examination, cervix is 4 cm dilated and membranes are intact. Different stages of the labor and different methods of the fetal monitoring and active management of third stage of labor. And okay, so this is the scenario in which the labor definition, the different stages of labor and the different methods of fetal monitoring and the active management of the labor is asked. So let's start from the definition of the labor. Okay, it is a process of regular, rhythmical, powerful, and painful contractions occurring at a rate of 1 to 3 per 10 minutes, bringing about the effacement and dilatation of the cervix and descent of the fetal presenting part, leading to the expulsion of the fetus. Or it is defined as a process in which regular, painful contractions bring about the effacement and dilatation of the cervix and descent of the presenting part, ultimately leading to expulsion of the fetus and the placenta from the mother. This is the definition of labor. There is also another scenario here that defines the labor, mechanism of labor, the management of normal labor, and the management of first, second, and third stage of labor, and the causes of prolonged labor, and the second stage labor, and the complications of third stage of labor. Okay, so we will discuss all the stages of labor and its management in detail in this section. Stages of labor. The first stage from onset of labor to the full dilatation of the cervix is the first stage of labor. Full dilatation is 10 centimeter. Okay. Now we are having latent phase and active phase in the first stage of labor. The latent phase is between the onset of the labor and 3 to 4 centimeter dilatation, and it is a process by a cervix shortens in length. This is a process by which the cervix shortens in length and it becomes included into the lower uterine segment. It is for about 3 to 8 hours. The active phase is between the end of the latent phase, that is 8 to 10% full dilatation occur in the active phase of labor, and the cervix dilatation occurs at 1 centimeter per hour, and it is about 2 to 6 hours. Okay, so 12 to 13 hours. Okay, active phase is 12 to 13 hours in the first stage of labor is about 12 to 13 hours in nulliparous woman, and it is about 8 hours in multiparous woman, and it consists of two phases, the latent phase and the active phase. In the latent phase 3 to 4 centimeter dilatation occur, and it is about 3 to 8 hours, and the active phase the 10 centimeter dilatation occur, and it is about 2 to 6 hours. Now the second stage of labor, it begins with full dilatation of the cervix and is completed with the birth of the baby. From dilatation of the cervix to the delivery, and in the primiparous it is 2 hours, and in multiparous it is of the duration of 1 hour. The causes of prolonged second stage of labor are malpresentation, size or position, ineffective contractions, ineffective maternal effect, and malposition. These are the causes of the prolonged second stage of labor. Cephalopelvic disproportion, medications, anesthesia, and if baby is too large, all these contracted pelvis and tumors of the soft tissue. All these are the causes of the prolonged second stage of labor. Now we are having the passive phase and the active stage. In passive phase, fetal head is relatively high in pelvis and no maternal arch to push. The active second stage is fetal head is low in the maternal pelvis and maternal arch to push started. So this was the second stage of labor. Now the third stage of labor, time from the delivery of the fetus till the delivery of the placenta, and it takes less than 30 minutes. The reasons of the prolonged third stage of labor are, okay, now the difference between obstructed and prolonged labor is that the prolonged labor is when combined duration of the first and second stage of labor is greater than 18 hours in primary and greater than 12 hours in multiparous woman. It is termed as prolonged labor. And obstructed labor is, it is the arrest of the vaginal delivery due to mechanical obstruction. Okay, the complications of the third stage of labor are PPH and retained placenta and acute inversion of the uterus and sudden postpartum collapse and obstetric trauma. These are the complications of the third stage of labor. Now coming towards the mechanism of labor. Series of changes in the fetal attitude, position of the presenting part, and the fetal body during the passage of the fetus through the birth canal. This occurs in the mechanism of labor, and we are having the definition that it is defined as a series of changes in the fetus attitude and position that the fetus undergo its passage through the birth canal. Now, there are 7 steps of the mechanism of labor. First of all, engagement occurs, then the descent, then the flexion, then the internal rotation, then the extension, then the restitution, and then the external rotation or expulsion. Okay. Now, engagement. It refers to the movement of the presenting part below the plane of the pelvic inlet. Engagement is said to be occurred when the widest part of the presenting part passes through the inlet, when the widest part of the fetal head fits the widest part of the pelvic inlet. The head only 2/5 palpable is engagement. Then descent occurs. It refers to the movement of the presenting part down through the birth canal from pelvic inlet to the pelvic floor, and it occurs due to the contractions and the amniotic fluid. Then there is descent during the first stage and passive phase, and second stage is secondary uterine contraction. The descent during active phase of second stage is helped by voluntary abdominal musculature and Valsalva maneuver. Then flexion occurs, the placement of fetal chin on thorax down to allow the nervous anterior posterior diameter of fetal head to the present in birth canal, and suboccipito-brachiotic occurs during active phase. As the fetal head comes into contact with the pelvic floor and cervical flexion occur. Then internal rotation occurs. The pelvic floor has gutter shape. It refers to the rotation of the position of fetal head from transverse to anterior posterior in the mid pelvis, like this. Then allows the widest diameter of the fetal head to present in the widest diameter of the mid pelvis, and then the extension occurs, that is the movement of the fetal chin away from the thorax. This allows to direct the axis of fetal head upward to the pelvic outlet. Then occiput fixes to symphysis pubis, and it acts as a fulcrum, and it is followed by crowning, a process in which the head extends and distends the vulva and no longer recedes between contractions. Then restitutions occur, that is the slight rotation of the occiput through the 1/8 of the circle, and the head passes through the vulva and aligns itself with the shoulder, and the shoulder then enters the pelvis obliquely. Then external rotation occurs. It refers to the further rotation of the occiput through the 1/8 of the circle in anterior posterior position to the transverse position. It allows the baby widest diameter of the shoulder to present to the widest diameter of the pelvis. Then expulsion occurs. It refers to the delivery of the shoulder and fetal body, anterior shoulder under symphysis pubis, and delivery first, and bilateral flexion of the trunk posteriorly, and the posterior shoulder deliver bilateral flexion of the trunk anteriorly. Okay, now the management of labor. We are having the management of first stage, the second stage, the third stage, and then we are having the partogram. Okay, so when the expulsion of the baby occurs, you have to cut the cord, then send the baby for Apgar's core, and then deliver the placenta, and lie the baby in transverse position, his head to one of his mother's side and the bottom across her abdomen at her other side. The Apgar's score is appearance, A P pulse, G grimace, A activity, and R is respiration. The 7 to 10 points is normal, and 4 to 6 requires the proper prevention or care of the baby. Now, the management of the baby, it is also management of the labor. It is also a very important topic for the obstetric subject. So, management of the baby labor on the admission, then during the first stage, then during the second stage, and during the third stage. On admission, first of all, the history of the patient is taken, and general examination is done, then the abdominal examination is done. Then assess the symphysiofundal height, then assess the lie, the presentation and engagement, then assess the uterine contractions by palpating the uterus directly, then assess the uterine contractions of by tachograph. Frequency and duration. Okay, on admission history and general examination is done, abdominal examination is done, that is assess the symphysis. Then vaginal examination is done by taking the consent and explaining the procedure. Then done by using index and middle fingers by passing it into the top of the vagina and the cervix. This procedure is done to examine the effacement, the cervix, the dilatation, and the presentation. If no cervix felt, means it is fully dilated. Then the first stage labor. Okay. The management of the first stage of labor. First of all, the provision of continuity of the care plus emotional support to the mother is provided. Then follow up the progress of labor plus timely interventions. If any abnormality, simple anesthesia is given, which is epidural, and encourage mobility and no restriction on diet. Adequate hydration to prevent ketoacidosis, and monitoring of the fetal well-being is done. Intermittent auscultation of the fetal heart rate, that is stethoscope and Doppler ultrasound, and observe the color of the liquor. And continuous external fetal monitoring is done using the CTG cardiotocography, and FBS, that is fetal scalp blood sampling. Then during the second stage, the woman should be discouraged from lying in supine or semi-supine position. The first sign of active phase of second stage is the maternal urge to push, so should be encouraged in organized manner. Episiotomy should be done when indicated. If meconium standing on amniotic fluid, then pass the nasopharyngeal suction, prevent meconium aspiration. The cord should be clamped after 1 to 2 minutes, and 80 ml of the blood transfuses from placenta to the baby and the pulsation ceases. After clamping the cord, the baby should be assessed for 1 minute Apgar score before placing on mother's abdomen, and Apgar score assessment at 1 to 5 and 10 minutes to check the condition of the baby. Then during third stage, after the delivery of the fetus, the placenta is allowed to separate spontaneously, and the signs of separation are lengthening of the cord, small gush of fluid blood from the placental bed, and rising of the uterine fundus above the umbilicus, and fundus becomes hard and globular. Then controlled cord traction is done. That is favored way of managing the third stage, and not performed if uterine contractions absent or else results in uterine invasion. Fails to expulse placenta 2% cases. If first attempt fails, next attempt is made after 10 minutes. If second attempt fails, then should be removed manually under general or regional anesthesia. The procedure is Brand and Trips technique. As the anterior shoulder of the baby is delivered, centometrine oxytocin is given 10 intravenously or intravascularly. A dish is placed at the introitus to collect the placenta and any blood loss. Left hand is placed on the abdomen or the uterine fundus, pushed upward and backward, while the right hand is used to apply the counter pressure and cross the cord downward and forward. With this, the placenta is separated. Now, partogram. It is a graphical representation of the progress of labor in the form of curve in graph. It is a composite graphical record of the key data, maternal and fetal during labor, and it entered against time on a single sheet of paper. Then vertical line is drawn, which is active phase, and the horizontal line is drawn, which is latent phase. The almost vertical line of the curve shows rapid progress of dilatation and acceleration of the labor. The components are patient data, that is cervicogram, cervical dilatation and descent of the presenting part. Then descent of the presenting part, the fetal heart rate, the amniotic fluid molding, the contractions per 10 minutes, the oxytocin, the liquor, and the meconium record, the drugs given, and intravenous fluids, the maternal vitals, that is BP and temperature, and a type of analgesia. The advantages of partogram. Time saving by avoiding writing in descriptive pattern. Abnormality can be recognized in first glance, and the transfer of information is easy in case of handover to the coming staff during change of the shift, and improvement of maternal morbidity and mortality. Okay. We will discuss the analgesia in the next video. So let's revise what we have discussed in the labor. So first of all, we discuss the scenario that there is fetal and what is the fetal and maternal anatomy? This one, okay. What is the fetal and maternal anatomy and related to labor, and important definitions and mechanism of labor. So this is the fetal and maternal anatomy: the pelvis, the pelvic inlet, the pelvic midcavity, and the pelvic outlet. Then we discuss the types of pelvis, which are gynecoid, android, anthropoid, and platyploid. The gynecoid is the most favorable for the labor. Then pelvic floor and perineum. Then we discuss the fetal presentations, which are sub-occipito-bregmatic presentation, occipito-frontal presentation, occipito-mental presentation, and submental bregmatic presentation. Then we discuss the important definitions, which are presentation, lie, attitude, engagement, position, station, deep transverse arrest, and augmentation of the labor. Then we discuss the definition of labor and the different stages of labor, which are the first stage. The first stage contains the latent phase and active phase, and the latent phase is 4 centimeter dilatation and 3 to 8 hours, and active phase is 8 to 10 centimeter full dilatation, and it is 2 to 6 hours. Then we discuss the second stage of labor and the causes of prolonged second stage. Then we discuss the passive phase and the active phase of second stage of labor. Then we discuss the third stage of labor. Then we discuss the complications of third stage of labor. Then we discuss the difference between obstructed and prolonged labor. This is prolonged labor, this is obstructive labor. Then we discuss the mechanism of labor. There are 7 steps, which are engagement. First we discuss what is engagement, then descent, then flexion, then internal rotation, then extension, then restitution, and then external rotation, and then expulsion. Then what we should do after the expulsion, we discuss that. Then we discuss the management of labor. So the management of labor on admission. Then we discuss the management of labor in the first stage of labor. Then we discuss the management of labor during second stage of labor, and then the management during third stage of labor. Then we discuss the partogram, that what is it and what are the advantages of partogram. In the next session, we will discuss the pain relief or analgesia, which are given during the labor, and what are the types of analgesias. And then we will discuss the abnormal labor, and then we will discuss the cephalocephalic disproportion in another section. Thanks for watching.